Thank you so much. Thank you so much. The idea was to have a true translational meeting with clinical and basic science sessions. So let's start with the first clinical session. I'm happy to call on stage the moderators that are Dr. Lecher van Leeuwarden and Professor Andrea Veltri. Please join me on stage.
Okay, thank you so much to the VHL Alliance for this kind invitation to me. Let's few words to introduce myself. I'm a radiologist involved in diagnosing and sometimes treating patients with VHL syndrome. I work in Italy, in northern western part in Turin University, and I'm so happy to be here with some friends in Italy, doctors and patients, and now in so worldwide involvement with so many and complex issues to learn for me, and I think for mostly of you. And so I am so happy to co-moderate this session with I call her Rachel because she has a surname too difficult for an Italian to end. So I think that we have to get started. So please a few words by my co-moderators, and then we can call the first speaker. Please, Rachel.
Good morning. I'm Karel van Leeuwarden, and I'm an endocrinologist working in UMC Utrecht. I'm the head of the clinical VHL program in our hospital. We will start with our clinical management session, and our first presenter is Professor Amit Tirosh, all well known to us. He leads the neuroendocrine oncology unit and the VHL clinical cancer at Sheba Medical Center in Tel Aviv. And he also established the Endocrine Neoplasia Translational Research Center and TIRE at Sheba Medical Center. Now we're looking forward to your presentation, Amit.
Thank you very much, Rachel. Thank you very much to the VHL Alliance, both for the opportunity to take part at developing the management recommendation for the VHL-related pancreatic manifestations. And thank you, I have plenty of thanks during the talk to the VHL Alliance and the organizers for the opportunity to present them to you today. So let's start from the third thank you to the subcommittee members of the recommendations for the management of patients with VHL with pancreatic manifestations. I have the privilege and pleasure to work with them. And today I'll focus mainly on the solid manifestations, namely pancreatic neuroendocrine tumors. This is one thing, and I'll try to be as practical as possible. And let's go right to the first recommendation. So the first thing that we had to define as a subcommittee was what is the minimal age to start screening for pancreatic manifestations in patients with VHL, and in which age we can stop screening in patients that did not develop any manifestation by then. And in addition, we had to define what is the interval between the scans for patients that did not have any pancreatic neuroendocrine tumors in the previous scan. The goal was to identify 95% of the patients with new lesions, and in the literature, the patient that was youngest with pancreatic neuroendocrine tumor was 10 years old at the time, and the youngest with the metastatic pancreatic NET was 11 years old. And based on that, and based on the subcommittee members' experience, we thought that starting the screening at the age of 15 years is more than sufficient to identify 95% of patients with pancreatic NET. And considering the high penetrance of the manifestations of VHL over the years, at the age of 65, if a patient did not develop any manifestation, then it is very reasonable to stop screening for pancreatic manifestations. Now, pancreatic NET in general are indolent tumors, and even if a patient develops a small pancreatic NET between the scans, let's say 3, 4, 5 centimeters, the risk that it will progress or even metastasize is extremely low. And based on that, we recommended that if a patient did not have any manifestation on a specific scan, then the interval until the next scan can be 2 years, but of course we should consider whether we need another annual scan to make sure that it is stable before we move forward and increase the intervals. The second question that we had is in what is the optimal setup for surveying patients with pancreatic NET in the context of VHL, of course. I'll call it in brief VPNet, VHL-related pancreatic neuroendocrine tumor. And here we had to balance between our optimal setup in which every patient receives the advice of an expert in VHL-associated tumors or VHL-related pancreatic NET. And on the other hand, our wish to reduce the burden on the patient and on the healthcare system, but mainly on the patients, in terms of stress, in terms of the number of scans that they anyways have to undergo. And if a patient has a small pancreatic NET, 1 centimeter, that we know in 2 consecutive scans that is stable, and there is no suspicious metastasis, in this case, we can definitely reassure both the physician and the patient that the risk for any progression or metastatic disease in the near future is extremely low. And in the case that the patient cannot be referred to a tertiary center or VHL expert center, we can reassure the physician and the patient that in small, stable, non-metastatic tumors, the follow-up can be in a non-expert center. I am not going to define what is a non-expert center, whether this is a NET expert center or another, but I think the idea is clear. And now if we have a patient with pancreatic neuroendocrine tumor, I want to discuss 3 tools that can aid us or cannot aid us with the follow-up. The first one is the biochemical biomarkers. Then I'll talk about the anatomic imaging and the functional imaging. So to start with the biochemical biomarkers, when we are talking about neuroendocrine tumors, we usually subgroup them into 2 groups. The first one is the specific biomarkers, namely those that are associated with specific endocrine syndromes, such as insulin and hypoglycemia, gastrin and recurrent peptic ulcers, etc. In the context of VHL, these are rare, okay? We do not see often gastrinomas, insulinomas, somatostatinoma, etc., although insulinomas have been described. In the case that a patient has a insulinoma or clinical symptoms that suggest this as a clinical diagnosis, then we recommend following the same biochemical and imaging workup suggested for patients with sporadic disease. Most of the guidelines for this are published by the European Neuroendocrine Tumor Society, the ENETS. But if we are talking about the non-specific biomarkers, which are similar to prostate-specific antigen, CA19-9, CA53, etc., in the context of neuroendocrine tumors, we are talking mainly on chromogranin A, which is a very non-specific biomarkers with plenty of false positive causing factors, including proton pump inhibitors and kidney failure, etc. And this biomarker is very inaccurate, and we do not recommend using it, not for surveillance, definitely not for screening. The other one is pancreatic polypeptide, which was shown to be in very strong correlation with the burden of VHL-related pancreatic NET. But here again, first, the predictive ability of the biomarker is relatively low, both the positive and the negative. And second, it is not available in most of the clinics or many clinical centers in the US, in the Europe, and in other parts of the world. So generally speaking, we do not recommend using biochemical biomarkers. And it is important to say that when we have very accurate and readily available anatomic imaging modalities, CT and MRI, that show the peanut from tiny size, and we can use them very easily and comfortably to follow patients, then we don't really need inaccurate biomarkers. And in line with that, when we are talking about anatomic imaging, both CT and MRI are excellent modalities to demonstrate the pancreatic net. It is important to know that when we are talking, especially on CT, contrast-enhanced CT is essential to demonstrate the pancreatic net. In non-contrast-enhanced CT, we cannot demonstrate the pancreatic neuroendocrine tumors. And both in MRI and CT, we should use the early arterial phase. And you can see it here, that when we're using the, can you see the marker? Yeah. When we're using a contrast-enhanced CT, you can see this pancreatic net very clearly, and it will appear again in the presentation, so it will look familiar in the future, I can promise you that. And between MRI and CT, both have similar accuracy in several retrospective studies. We recommended the use of MRI over CT because of irradiation consideration. We don't have evidence that the recurrent CT increases secondary malignancies in VHL, but we do not have evidence that it does not. So we recommend using MRI over CT out of caution. We can use, because patients with VHL will undergo imaging for other visceral manifestations, usually the kidney, but also for adrenal, maybe for non-adrenal paragangliomas. We can use them to screen or survey pancreatic net. But again, it is important to make sure that we have contrast-enhanced imaging, or in MRI that we have at least the T2 and diffusion phases. In terms of endoscopic ultrasound, I'll say it very briefly. Endoscopic ultrasound is by far the most sensitive way to demonstrate pancreatic net. But in VHL, we do not need to know about any tiny pancreatic net. If a patient has 2 or 3 millimeter pancreatic net, it will not affect the management, it will not affect the prognosis, and it will add a lot of stress to several patients, and we have to take this into consideration. In addition, endoscopic ultrasound is an invasive procedure, and we have to think about that much more than in a patient with sporadic neuroendocrine tumor. And for this reason, we do not recommend using this regularly, not for screening and also not for surveillance. The exceptions, which are really exceptions, are patients that have atypical lesion, namely one that grows rapidly, don't show uptake to DOTATATE, is not enhancing on CT or MRI. For this patient, we recommend doing endoscopic ultrasound and sampling the lesion. And also, if a patient has a contraindication for CT MRI for claustrophobia or something like that, EUS can be considered. And the last exception is patients that need to undergo ablation for pancreatic net. This is a valid option. In patients with very high risk for surgery that we do have indication for surgical intervention for specific pancreatic net, radiofrequency ablation can be considered. In terms of functional imaging, I'll give a very, very brief intro. The main functional imaging that we use in the context of sporadic pancreatic net or sporadic neuroendocrine tumors in general is gallium-68 DOTATATE. DOTATATE is a radio-labeled somatostatin analog, and the somatostatin receptors are typically expressed on the cell membranes of well-differentiated neuroendocrine tumors. The more the tumor cells are differentiated, the more probable they will express somatostatin receptors. And we can use it both for imaging and for treatment. And you can see here in the low-grade disease, you can see here the metastatic disease in the liver shown very clearly with gallium-68 DOTATATE PET-CT, and you cannot see it in high-grade disease. In contrast to the DOTATATE PET-CT, when we're using fluorodeoxyglucose PET-CT, which is based, of course, on glucose uptake, the higher the disease grade, the more aggressive the disease, you will see higher uptake of FDG on FDG PET-CT. And we can use these two modalities as what we call dual tracer imaging. If we see high uptake of DOTATATE, then this is well differentiated, tends to be indolent, lower aggressiveness, and if we see a patient with a high uptake of FDG and no uptake of DOTATATE, we'll be more prone to give chemotherapy and watch more closely. In VHL, this is not the case, because in VHL deficient cells, we see increased, we can see upregulation of the glucose transporters, and we see uptake of glucose also by indolent cells. And you can see here on the right, a patient from our clinic that has or had a pancreatic net in the head of the pancreas. You can see the uptake of FDG here, and you can see uptake of DOTATATE here. And both of them show more or less the same standardized uptake value, SUV, okay? The quantification of the uptake of the radiotracer. And after resection, we saw that there was no mitosis and the Ki67 proliferative index was very low. And this shows us that there is no correlation between the FDG uptake and the aggressiveness or the differentiation of VHL-related pancreatic net. The other point is that DOTATATE PET-CT shows uptake in practically all VHL-associated neoplasms. Renal cell carcinoma and endoliphatic sac tumor, epididymal cyst adenoma, and also angioblastoma. And you can see here patient, again, this is the same patient, by the way, with the pancreatic net. You can see the lesions in the spine on MRI, and you can see the uptake of DOTATATE. And I would like to refer you both for a recent paper by Dr. Van Leeuwarden, I promised you that you will feel at home here, from Dr. Van Leeuwarden group, and they presented this in a poster in this meeting as well, that shows that hemangioblastoma is not only a matter of vascular structure or capture of the DOTATATE by the tumors, but also expression of somatostatin receptor by the hemangioblastomas. So it might even in the future be considered for a guided treatment with DOTATATE. We don't have any data about that. But the fact that all the VHL-associated tumors, show some expression of somatostatin receptors is very interesting and might be clinically meaningful in the future. Okay, now, because in patients with VHL, the pretest probability for pancreatic net is extremely high, if I have a patient with VHL and we are doing a CT of the abdomen and I see a lesion in the pancreas that is contrast enhancing, we can be very close to sure that we are talking about VHL-associated pancreatic neuroendocrine tumor. For this reason, we will not go and sample it, especially because we know that it is typically a very indolent disease, grade 1 and non-functional. And for this reason, we need indirect factors that will guide us on the risk of these tumors to progress or metastasize. The first and most obvious measure is the size of the tumor, and we know that tumors that are smaller than 1.2, 1.5 centimeters, and there are several theories about that, the risk of this tumor to progress, to grow, and definitely to metastasize is extremely low, and we even can consider following them every second year, because at least if we know that in one scan that they are stable, but in general, if I see a small lesion in the pancreas, there is no stress around that. In a patient with larger tumors, 3 centimeters or larger, we definitely do recommend to resect them. And in the NIH protocol, and I think that Dr. Neri Snilbolo will speak about it later on in this meeting, tumors that are between 2 and 3 centimeters in the head of the pancreas, at least in the NIH, recommend resecting this, and we recommended at least considering resection of these tumors. For tumors in between 1 and 2 or 3 centimeters, we recommend following every year. Now, there was a very hot debate or very active publication on the connection between germline VHL genotype and the ability to predict the behavior of pancreatic neuroendocrine tumors. And as you can see in the bottom of the slide, I'm involved in this slightly. And
my apologies for that. We have to come to a conclusion in order to stay on time. So if you can sum up and
one last
your
slide.
keynotes. Thanks.
Yeah. So as you can see, there are plenty of data, some suggesting exon 3, some suggesting exon 1, even specific sites. But the variant type was rarely considered. And put it very simply, we don't think that based on the germline VHL genotype, we can plan the algorithm, the management or surveillance algorithm for patients with VHL. Last slide, I promise. So we had a beautiful paragraph written on the systemic therapy for patients with VHL-related pancreatic net in the guidelines, but then you came with this belzutifan thing and ruined everything. And now we have the belzutifan that is definitely the intervention of choice for patients with VHL-related pancreatic net. And here I show some data from the recent publication by Dr. Elze and the entire group, Dr. Jonas, Dr. Sevinasan, Dr. Iliopoulos, and everybody, that show that in patients with VHL-related pancreatic net, here we have 22 patients, at least 2 had stable disease, the other had either partial or complete response, and same was true for patients with cystic disease. We show here patients from our clinic with very nice improvement in the cystic disease, which has also impact on their health in terms of risk for diabetes, etc. That's all. Thank you very much, and I'm happy to answer questions.
Okay, due to time issues, I think we have room for one question. No questions?
One there.
Yes.
Please, just
Please,
one.
just come to the microphone.
If you have an image on the PET scan or in the galleon, do you need, you necessarily need biopsy to see that it's a neuroendocrine tumor or not? The image is enough? So,
if I can repeat the question, if you have an uptake on FDG PET-CT and on DOTATATE PET-CT, whether we need to do a biopsy.
A biopsy, yes.
So maybe the main message on this issue is that I don't think we can rely on the DOTATATE and FDG PET-CT for this type of decisions. If you see a lesion that is stable, if the lesion is located in the pancreas and is stable, then FDG will not help you at all. If you have patient with pancreatic net in the tail of the pancreas, and right beside it, you can see a small lesion with uptake of DOTATATE or FDG, the differential diagnosis might be metastasis from the pancreatic net, paraganglioma, pheochromocytoma, renal cell carcinoma, etc. So the considerations are very wide, and we just have to make the correct list of differential diagnosis for this case. But I don't think you can rely on DOTATATE and FDG PET-CT for these cases.
Well, I'm considering in a context of VHL, a pancreatic lesion that captate DOTA as a neuroendocrine tumor. So I don't think perhaps we need a biopsy for that. I don't know the opinion of others, but this is something I'd like to have your opinion. If you really need to have a biopsy in a situation of a VHL contest and a pancreatic lesion that uptake PET-DOTA.
No, definitely not. In general, we do not need biopsy for patients with pancreatic net,
Okay.
And they will typically show DOTATATE uptake. So I think we agree.
Yeah, my comment, of course, not for diagnosing, but sometimes for managing. So it depends which is the strategy after that, surgery, not surgery, and sometimes the proliferation rate and other markers may be useful, even though different is if it is just a metastatic disease or just a nodule there. However, maybe sometimes it should be decided on a multidisciplinary board decision. Okay, I feel that we should go forward, thank you, with the next talk by Professor Pacak, sorry for my pronunciation, is well-known endocrinologist at NIH. For his talk today is about the identification, surveillance, and treatment for syndrome-related pheochromocytomas and paragangliomas. Please.
So, ladies and gentlemen, good morning. First of all, I would like to thank the organizing committee, of course, VHL Alliance, as well as Italian colleagues for the kind invitation really great honor and pleasure to be here today. From my title, as you see, I will talk a little bit about identification, surveillance, and treatment of VHL-related pheochromocytoma and paraganglioma. The data I'm going to present, some of those data came, from the NIH. That I left actually a few weeks ago, and then also, from the colleague from Europe as well as from US. So when I talk about the pheoparaganglioma, as you know, they are neuroendocrine tumors and they produce catecholamines, but the problem is that, only about 70% of them release catecholamines, so this is why the biochemical diagnosis is based on the measurement of metanephrines. So the measurement of catecholamines is completely obsolete at the present time, because, those metabolites are released in approximately 98%. All the pheoparagangliomas, including the VHL, are considered to have metastatic potential, so the term benign is no longer used and should not be used, and currently metastatic pheoparaganglioma is defined as disease presence in bones and lymphatic nodes. The annual incidence of these tumors is actually increasing, but this is question mark, because many patients are going through surveillance, as well as you know, CT and MRI is around every corner. But it's approximately about 8 to 10 cases per 1 million of the population. The paradigm, how we actually diagnose the pheoparaganglioma shifted as well. So previously it was based on, the symptomatic presentation, but because the patients are coming much earlier these days, as you see, during the last, I would say 15 years or so, it's especially based on the imaging and based on incidentalomas, because, many patients are actually imaged these days because of, some other unrelated diseases, symptoms, signs, and problems, and therefore, those patients, they have actually some discovery of adrenal tumors. The genetic is becoming also very important, and before it was approximately 4 or 5% those that they were actually diagnosed based on the genetics, and today it's approximately 10%. And then we talk about the percentage, the pheochromocytoma, paraganglioma, especially those for the VHL. So this is, the meta-analysis and overall statistics, and approximately, 40% of those, they are females, and about 55-60% are males in terms of VHL pheochromocytoma. You can see the continuing the genetic discovery. We have many genes these days, approximately 25 genes that are related to pathogenesis of pheochromocytoma paraganglioma. The last one is SUCLG2 that belongs to Krebs cycle, and we discovered that gene in 2022. But what is important, we actually divide, even despite that we have so many genes, we divide actually those genes into genetic cluster. The first actually the division of those, the genetic cluster came in 2011. That came from France, and we had the 2 molecular clusters. But when you look at the VHL, it's definitely in the cluster 1, and it's a cluster 1 as a cluster 1b practically. Then later on, we came together with under TCGA activity. That was in 2017 for molecular cluster, and in collaboration with many colleagues worldwide, we came in 2022 with 7 molecular clusters, but the VHL is still staying, in the cluster 1, which is cluster 1b. And then we talk about those clusters. I think that this is the most important, despite what I said, 4 or 7 molecular clusters. Now the most important cluster 1 and cluster 2. And when you look at the cluster 1, you have here VHL. So because, the cluster 1 is related to Krebs cycle, we will not talk about the Krebs cycle because VHL is close, but, it's not in the Krebs cycle, but it's related to hypoxia signaling pathway. And then all these tumors are complicated in terms of They have a multiplicity recurrence, they have an aggressive problematic behavior, metastatic disease, except one, and this is the VHL, because those patients that they have a VHL pheo/paraganglioma, they don't have the metastatic disease commonly, so it's rather rarely, so approximately 5% they will develop metastatic disease. When you look at the clusters, and especially cluster 1, those patients, they have a noradrenergic biochemical phenotype. So practically impossible that the patient is coming, for example, to the clinic and have, adrenergic phenotype, which means increased epinephrine / actually metanephrine, and claiming that the patient has the VHL. Yes, there are some exceptions because the medicine is not 100%, but most of these patients, 95% of those patients, except for those that they have a metastatic disease, some of them, and this is very unique, they have a noradrenergic phenotype. But why the patients sometimes are coming a little bit late? If they don't have for example, surveillance, or the patient, they don't have a symptoms and signs, and this is exactly in this third figure that the amount of catecholamines actually in these tumors is pretty low. So those patients that they have a VHL, for example, pheochromocytoma, they don't know about this tumor because they don't have a symptoms and signs related to catecholamine excess. So the most important is either to measure metanephrines or actually to do the imaging studies. About the prevalence, so this is pretty well known. It's approximately 25% of those patients with VHL will develop pheochromocytoma. Now we have a type 1 and type 2. I will not go into that, but we know that, the likelihood to have pheochromocytoma in type 1 is very low compared to type 2. So overall, as I said, approximately 25%. But when you look at the type 2, this is much higher. It's approximately, it depends what you read, is between 30 to 50%. So this is very, very, very high. But, when we put together type 1 and type 2, of course, we will end up with the number between 20 and 30%. Sometimes the question, what we should do, the urine or, the plasma, and here you have, sensitivity and specificity for plasma and urine for all the metabolites. When I talk about metabolites, as I mentioned before, it's metanephrine or metanephrine, and also metabolite of dopamine is methoxytyramine. You can see that the sensitivity is slightly higher, and the specificity is practically the same. But it depends who is the patient, how should we apply. And when we talk about the VHL patients, and here at the symposium, of course, those patients will have a high risk. The high risk means, previous history, for example, this is the history of previous pheochromocytoma / paraganglioma, hereditary risk, or, incidentaloma. And in that case, and the data are pretty solid, you should not actually prefer the urine test. You should prefer, the plasma test, and meaning, the measurement of plasma metanephrines. Here is the pre and post probability, which is interesting, how we can actually approach, the problem in terms of, if there is elevation of, for example, plasma metabolites. And it depends, who is the patient. And as I mentioned before, and because we are talking about VHL, let's say the patient has adrenal incidentaloma, or, so it's high-risk patient, as I mentioned, family history, genetic predisposition. Then you will look at the metanephrine. So pre-test probabilities is already high in these high-risk patients, and you can see here is about 50%. And if you get results, for example, you will have incidentaloma, and metanephrines, for example, here normetanephrine will be 2 times above the upper reference limit, is practically 100% that the patient has actually pheochromocytoma. And because we are talking about VHL, of course, will be related to VHL. So we prefer, the plasma versus actually urine, as I mentioned before, in high-risk patients. We are not absolutely sure what's going on between the upper reference limit and the 2 times above the upper reference limit, which is actually gray zone. We are using the clonidine suppression test. I will not go into that, but it's very useful actually before you go into imaging studies that are very expensive, $10,000 at least in US, I don't know in Europe, but it's extremely, extremely expensive, and you can see the sensitivity, specificity, and what is good for the VHL audience, because they have a noradrenergic phenotype. This is exactly when the clonidine test should be used, because it cannot be used for those that they have an adrenergic phenotype. We have also age-related upper reference limit. You should know about it, because there is sometimes, confusion and question mark, how to read something, especially, in kids, because you know that they can develop actually those tumors, so you should be aware of that. And when we take, age-related the upper reference limit, we can improve the sensitivity and specificity, especially for those that they have only slightly elevated metabolites, especially here normetanephrine. So the update on the clinical characteristics, there are the different one we added, just recently. There is also something which is related to weakness. It's related to body mass index, as well as, for example, nausea and weight loss. And if you have more than 3 symptoms, and those symptoms are hyperhidrosis, palpitation, pale, tremor, and nausea, together, with low body mass index, there is very high, actually, chance that the patient will have the pheochromocytoma/paraganglioma. There is some echo. So sometimes about the resistant hypertension, how we should approach the resistant hypertension, because the physician thinks that there is resistant hypertension, patient must have a pheochromocytoma. The answer is no, because the resistant hypertension must be associated with symptoms and signs related to catecholamine excess, and then this is exactly the time when we are talking about having pheochromocytoma, paraganglioma. About the surveillance, there are no really big changes. We start, at the age less than 5 years, about history physical examination, usually from age 1, measuring blood pressure and heart rate from age 2. What is important, about the metanephrine start at age 5, and it will be stopped or cease, around age 65. And of course, the MRI is preferable method, because, there is no actually radiation. And this is the same that the newest guidelines in 2023. I will not go into that, because, they practically copy, everything, what was there, before. There are not big, exceptions. About the imaging studies, I just wanted to say that, the pheochromocytoma was born, to be imaged. But for VHL patients, especially fluorodopa, that was introduced in 2002. And there are not really very good studies related to VHL and fluorodopa. They are scattered, but, we did something that we published just, recently. 12 patients, and you can see the fluorodopa definitely scores the highest. The DOTATATE is not really the best, about 50–55%, and this is the same for the MIBG. So the question is, if we don't have a fluorodopa, what we should use, because, especially in the United States, fluorodopa is not available. So it's either MIBG or gallium dotatate, but we don't have, very good studies. So this is open area for research. But we know that, for example, gallium dotatate is very good, for the metastatic lesions. We just published, the data related, to spine. Unfortunately, VHL patients were not included because we did not have them, but was even better than MRI. And you can also think about the FDG. Sometimes physicians are coming, should we use, for example, dotatate gallium-68 or copper-64, doesn't matter. You can see here, the data are pretty much the same, so no any panic. And of course, the radiotherapy treatment, either, using PRRT or, the Azedra. Azedra is not available, but we can use the conventional MIBG, and the conventional MIBG gives you pretty much the same results. Azedra was about 90%, conventional MIBG is about 82%. And be aware of BRRT, that there are some problems related also to VHL patients.
Please,
and I mentioned especially one increase in catecholamines. We call it catecholamines-related or release syndrome, so be aware actually of that. And this is the slide that is showing, the belzutifan. This is new study that will be published next week. And, I just wanted to show you that, and that would be related also to VHL patients, and maybe patients that they have a HIF2 alpha upregulation, that we can normalize, the high levels of norepinephrine/normetanephrine in 3 hours. Why it's important? Because if the patient has in a crisis, catecholamine crisis, and the ICU, and using belzutifan, this can be actually new and very interesting indication.
Can you
and
go
the last slide?
The conclusion? Yeah.
The last slide is about, that there are various treatments for tyrosine kinase inhibitors. I will not go into those, because they are a little bit off for the VHL. However, they may work very well, but just wanted to let you know that there are promising studies with sunitinib, cabozantinib, and anlotinib. Will not go into details, because, you heard that belzutifan in some patients, especially in VHL, may be better. And, I would like to thank, the colleagues, especially from NIH, other colleagues as well as, and of course, my wife, Michaela, for her very tremendous and very unique support. And I will stop here, and thank you so much.
Thank you for your excellent presentation, Professor Pacak. The floor is open for discussion.
Just to inform the audience and maybe get your comment too, there is an ongoing trial right now, the results are not yet known, about metastatic pheochromocytoma paraganglioma in VHL patients treated with belzutifan. The second thing is that there is an also arm in this trial that enrolls localized pheochromocytoma, not even metastatic, instead of surgery, to treat them with belzutifan. So I can't comment on the ongoing results, but there's something to keep an eye on it.
Yeah, thank you so much. So I am aware of both. So we are sort of part of the first one. So for patients, with metastatic pheochromocytoma across all, cluster 1, cluster 2. Unfortunately, we still don't have results, because everything is most likely cooking, and of course we cannot get to those results, but I'm aware of those results. Will be very interesting. I am sort of skeptical for the cluster 2, but we will see. But for the cluster 1, I think if we will get some very interesting data, it will be good. And as I mentioned, what we are actually publishing next week about the belzutifan, I feel that would be very good indication for some patients at the ICUs as well, if they go into difficult scenario like, after chemotherapy or radiotherapy.
Karel, thank you. Again, I'm not talking and revealing any type of results from the clinical
Sure.
trial. Personal experience, I treated people with metastatic paraganglioma, that they have succinase dehydrogenase germline mutations. There are incredible responses.
Yeah, and that is exactly cluster 1, and this is exactly what I am actually predicting, that there will be very good responses, because HIF2 alpha is in some, maybe not all of them, because there are some so subclusters, but I think overall that can be very promising indication. Thank you so much. That was good comment.
Good morning. Thank you for the excellent presentation. My name is Wouter Zandé from the Netherlands. So I was wondering, for a second adrenalectomy for VHL PHEOs, you can consider partial adrenalectomy, but I find the results on preventing adrenal insufficiency a bit disappointing, because the percentage is still quite high in the patients to develop adrenal insufficiency. So I was wondering what your opinion is on the indication for partial adrenalectomy as a first surgery in patients with a VHL-PHEO.
So your question is, if the patient has a pheochromocytoma, that will be, the first diagnosis, and then whether, the patient should have, partial adrenalectomy.
Indeed.
My answer is definitely yes.
Thank you.
And I will tell you why. I think, and we have a surgeons in the audience, and I think during this meeting they will comment much better than I can, but in hands of very good surgeons, this can happen, and the recurrence rate, it depends what you read. If you read, the article from very experienced surgeons, it's up to between 4 and I would say 10%. If you have less experienced surgeons, it could be between 15 and 30%. But also it depends on the size of the tumor. Of course, if the tumor is, very large, you will not be able to do the partial adrenalectomy. This was a good point. Thank you.
I do have questions about the relationship between VHL pathway and PHEO. We have historic data reporting almost 5 to 10% mutation of like somatic loss of function in the sporadic setting. Do you think this is a realistic figure, or would you expect it's in a way underestimated owing to other mechanisms of VHL inactivation in sporadic pheochromocytoma?
So you are talking about, the sporadic mutation in the pheochromocytoma paraganglioma, whether it is underestimated or not.
Yes.
There are, very nice papers from Dr. Wallander. Maybe I'm not sure whether I pronounced the name correctly, from Sweden. And there are approximately 20%, up to 20% de novo mutation for the VHL, and you can find, somatic mutation. In terms of approach to those patients, for example, the clinical management, including surgical approach, I don't think that there would be any difference, although I am not absolutely sure how everything will go with the, for example, recurrent pheochromocytoma after surgery. I don't have enough information, but overall, we approach those patients the same way as we would approach the patient with germline mutation. But it's interesting because this could be interesting study, to compare somatic versus germline or de novo.
Thank you.
Okay, thank you again. So, and I'm calling as a preferred abstract Francesca Correa for presentation of her studies as a PhD student in distincting genomic and immune profiles of kidney cysts and clear cell renal cell carcinomas in von Hippel-Lindau syndrome. Please, Francesca.
Okay, thank you. So good morning. It's a pleasure for me to be here, and I want to thank VHL Alliance and the organizing committee for giving me the opportunity to present you today the work that we've been doing on kidney cysts and clear cell renal cell carcinomas in a VHL disease patient. So as you know, renal involvement in VHL disease is characterized by multiple bilateral clear cell renal cell carcinomas and kidney cysts that can develop throughout the entire lifetime of these patients. And according to the observation of these multiple lesions developing, as well as of small foci of carcinoma within the renal epithelium, cyst epithelium walls, had led to postulate this model of molecular pathogenesis of kidney cancer, according to which renal cysts are considered as precursor lesions of clear cell renal cell carcinoma. And indeed, according to this model that was proposed back in 2003 by Professor William Kaelin, VHL disease patients are heterozygotes for VHL gene in all the cells of their body. And then the somatic loss of the remaining wild-type VHL allele gives rise to renal cysts that can eventually progress to solid tumors after the acquisition of additional mutations at non-VHL loci. However, despite being an attractive theory, this model was then challenged by different studies and still remains debated, essentially due to the lack of a direct molecular evidence of cysts to tumor evolution. This has mostly been hindered by the lack of molecular data on kidney cysts due to the fact that these lesions are generally considered clinically indolent and so not often surgically removed in these patients. But thanks to the clinical and research VHL program of our institute, we had the opportunity to better address these two open questions concerning the molecular pathogenesis of kidney cancer in VHL disease that are, on one hand, trying to understand if cysts are indeed always necessary precursor lesions of clear cell renal cell carcinoma, and on the other hand, trying to understand if additional mutations in CCR/CC driver genes are really required for tumorigenesis. And to do so, we set up a pilot study on a first 56-year-old male VHL patient who carried this likely pathogenic germline variant in VHL gene and who presented with more than 20 distinct renal tumors and 81 renal cysts in both kidneys. The patient underwent radical nephrectomy of the left kidney, along with partial nephrectomies and tumor ablations of the right kidney. And after surgery, 6 independent tumors without necrosis or hemorrhage, 4 renal cysts, and 1 normal renal parenchyma samples were selected by a dedicated pathologist to be examined with at the level of histopathology, bulk RNA sequencing, and whole genome sequencing profiling, to get a more comprehensive characterization of the molecular landscape of these different lesions, all developing in the same patient, so with the same genetic background and host environment. So what we found at the histopathological level, all the 6 tumors were diagnosed as clear cell renal cell carcinomas with a size range spanning from 0.5 to 5 centimeters. They were all early stage and low-grade tumors, with the exception of a lesion 1, the largest, that instead exhibited a locally advanced tumor stage, and L4 that was assigned a Furman grade 3. Instead, diagnosis of simple cysts was made for the remaining 4 cystic lesions. Looking at the whole transcriptome level, we found with the unsupervised principal component analysis that the 2 groups clearly clustered based on their histological characteristics. In this, as you can see here, principal component 1 clearly separated the group of cysts from tumors, highlighting divergent transcriptional profiles between these 2 lesion types, while PC2 further separated tumors one from each other, so also highlighting a certain degree of intertumor heterogeneity at the transcriptional level. Next, we also compared cysts and tumors by differential gene expression analysis, and what we found is that the most significantly differentially expressed genes between these 2 groups were markers of distinct segments of the nephron. That is, when compared to tumors, cysts mostly express genes that are markers of the distal portion of the nephron, so including loop of Henle, distal tubules, and collecting duct markers, as opposed to tumors that instead mostly express markers of the proximal tubules. And also looking then at tumors, when compared to cysts, the most highly expressed genes in this case were the canonical CCR/CC markers, which include markers of the hypoxia response, that we also confirmed to be specifically expressed only in tumors and not in cysts nor in the normal renal parenchyma sample. And we lastly also confirmed these divergent transcriptional profiles by pathway enrichment analysis. And as you can see here, again, when compared to cysts, tumors presented an enrichment in genes involved in the glycolysis pathway and in cellular response to hypoxia, while cysts mostly expressed genes involved in extracellular matrix organization and inflammatory response. So next, we also characterize these lesions at the whole genome level. At first by comparing all the high-quality single nucleotide variant sets among the different lesions. And in particular, we calculated the percentage of unique or shared somatic variants for each tumor and cyst, and then considered this metric as a proxy of the degree of genomic relatedness among the samples. And as you can see, the results of this quantitative assessment clearly showed that the majority of our samples in this patient were clonally independent, as indicated by the high percentage of unique somatic variants that ranged between 80 to 99%. So this suggesting that, with few exceptions, All these different renal lesions in this patient likely arose independently in the kidney of this individual. And next, we also looked at whole genome level at the somatic copy number alterations. And as you can clearly see here, all tumors presented an altered somatic copy number alteration profile with the universal observed loss of chromosome 3 or 3p and 5 or 5q gain in all tumors, while cysts presented a normal somatic copy number landscape with no detectable loss of chromosome 3 or 3p. That's suggestive of the VHL heterozygote status in cysts, at least at the copy number level. And then we also confirmed this by looking and restricting then the analysis on the coding driver landscape of all these lesions. And what we found is that the majority of our tumors actually lacked additional pathogenic or likely pathogenic variants in the canonical sporadic CCR/CC driver genes, with the exception of lesion 4, the grade 3 tumor that instead presented this novel pathogenic variant in the BAP1 gene. Instead, all the others only had the VHL inactivation due to the germline first hit and the somatic loss of chromosome 3 or 3p. And again, instead we confirmed that cysts lacked also the second somatic hit in VHL gene, as well as the copy number event on chromosome 3. And lastly, to also try to see if we could find some level of convergence among cysts and tumors developing in the same patient, we looked again at the whole genome level, but this time looking for mutational patterns and signatures. And here is just an example for those of you who may not be super familiar with the concept of mutational signatures. Basically, this is the trinucleotide mutational spectrum of the lung cancer genome from a smoker, which is basically just a way to classify somatic variants by considering for each of these 6 main single base substitution classes also the base pairs immediately adjacent 5' and 3' to the somatic mutation, so generating 96 possible mutation classes. And this type of classification is the one generally used for the extraction of mutational signatures. Indeed, you can see that it is possible to decompose this spectrum into the multiple components responsible for this mutational pattern, each contributing in different proportion to these mutations. In this case, for example, signature 4 was the major contributor, and it's been associated with the carcinogens generated by tobacco smoke. And so similarly, we extracted mutational signatures from our samples de novo, and then we related these to the known signatures of the cosmic catalog. And what we found is that all our samples presented mutations that could be assigned to these 5 mutational signatures here. In particular, more than 50% of variants could be assigned to signature 40 A and B, and this latter has been recently described to be consistently and specifically associated with CCR/CC, as well as other signatures like 5 and 1 that instead are due to clock-like mutagenic processes. But unfortunately, most of them are still of unknown etiology. And interestingly, when we then looked at the activity of these signatures in each of the samples, what we found is that most of these were present, as you can see, in all the samples, and also with a conserved proportion in each of them. So we could find some level of convergence in the types of mutations that were found across all these lesions, despite being clonally independent and likely arising from distinct nephron segments. And so in conclusion, going back to the original model proposed by Kaylin, and for sure holding this true in certain circumstances, with our observations, we can suggest that for sure VHL inactivation is required for tumorigenesis, but seems not to be necessarily required for renal cyst development, as we observed that our cysts are still heterozygotes for VHL gene. Then we also demonstrated and showed that tumors and cysts in this patient were clonally independent, showing very distinct sets of somatic variants. And we think this genomic identity could be linked also to the distinct nephron segment origins of these 2 lesion types. And lastly, we also observed that the majority of our tumors lacked additional pathogenic mutations in the CCR/CC driver genes, So possibly suggesting that these are not necessary for tumorigenesis at least. And with this, I'm done, and I would like to thank all the Urological Research Institute, in particular Professor Andrea Salonia, Dr. Alessandro Larcher, and Dr. Iselin Rowe, for giving me the opportunity to work on this project, and all the other collaborators from our hospital. And thank you for the attention.
Okay. I feel that we can go forward, and it is my pleasure to invite my co-chairman here in this session to present her topic to you all. Always in the setting of clinical management, but looking at the future. We are now presenting the talk by Rachel von Leeuward, maybe no, however, on radiation therapy in ccRCC, potential application in our disease, so VHL. Please, Rachel.
Well, thank you to my co-chair. This is my disclosure. And the main question I will address during my presentation is whether radiation therapy is a safe and effective option for renal cell carcinomas in patients with VHL. And I know that there are some concerns regarding radiotherapy in renal cell carcinomas, which are a bit historical, but still I would like to address them. So the first concern is, are renal cell carcinomas radiosensitive? Of course, a very important concern is whether surgery after radiation might lead to higher morbidity. We don't have the data yet, so we do need long-term data on this issue. Radiation might induce tumorigenesis, especially in our patient group, which is quite young. They develop renal cell carcinomas at a young age, so they have a high potency to develop renal cell carcinomas in the future, especially maybe if there is radiation in the healthy tissue. And two, technical concerns are the adjacent intestines, for example. Radiation can cause significant toxicity in the small intestine, but also the kidney motion should be taken into account with each respiration when applying radiation. So I'm going to address the first bullet point, the radiosensitivity in renal cell carcinomas, because this has been an issue for a while, where the renal cell carcinomas are radiosensitive. And what happens is that the radiosensitivity is determined by endothelial cell apoptosis. And the induction of endothelial cell apoptosis depends on the radiation schedule. And in the past, we used conventional radiotherapy. And the characteristic of conventional radiotherapy is that it's low dose fractionated. So you give a low dose of radiotherapy. And we know that conventional radiotherapy induces hypoxia, but as a counter reaction, also reoxygenation occurs through a pathway we all know here, the HIF-1 alpha pathway, which leads to growth factor development, leading to radioresistance. So the HIF-1 alpha pathway leads to radioresistance in patients who are treated with conventional radiation therapy. And this is the difference between conventional radiotherapy and stereotactic radiotherapy. Here on the left side, we see a conventional radiotherapy. This is a very old image. It's actually an X-ray planning for prostate radiation. And what we can see here in the middle 4 squares, there is the same amount of radiation applied. So all the adjacent organs, like the bladder, receive the same amount of radiation as the prostate does. And that is completely different from what we do nowadays. We see this image here. I think most of you know it. It's stereotactic radiotherapy, where we see all the blue lines here, which are the different angles that radiotherapy is being administered. And we have this focal point of interest in the middle, which is the renal cell carcinoma, in fact. And the highest dose of radiation is only in this spot. And here there's only a low amount of radiation. And by applying stereotactic radiotherapy, we are bypassing the HIF-1 alpha pathway, and the ceramide pathway is turned out, which is turned on, which leads to cell death quite permanently. So that's a different pathway in stereotactic radiotherapy, and that's why we don't see the radioresistance in stereotactic radiotherapy. And the dose volume here we apply for renal cell carcinomas is a volume of 50 gray, and in the past it was like 2 grays each session for conventional radiotherapy. So it's a huge difference between the amount of radiotherapy. So what I would like to focus on, because this is what we're interested in Utrecht, is the application of the MR-Linac. And for those of you who have not heard about it, at the end of the last century, one of the professors in the radiation department of Utrecht found that there was an unmet need, because conventional radiotherapy, it was not precise enough to treat tumors in general. So he invented a machine that combined the MRI scanner with the linear accelerator, so the radiotherapy. He decided in 2004, we can see here the MRI scanner and the beam, the linear accelerator, and in the following years, he developed prototypes. And then eventually, in 2014, Philips and Elekta were interested in this machine. So Philips for the MRI scanner, Elekta for the radiation, and together they invested in this new machine, which came available in 2018 in our hospital. And this was the first MR-Linac. You can see here in the images below, it's a huge machine. You can see here by the people who are standing next to it, and it was transported through the roof into our hospital. So this is what we call MR-guided radiotherapy, which combines the MRI Tesla, the 1.5 Tesla, with a linear accelerated. And a gating technique is applied here, which also refers to one of my the last 2 technical points, concerns about radiotherapy, is that we can use gating with the MR-Linac, which means that the beam can be switched off quite rapidly, on and off. So if the organ of interest falls out of the planned position, then the beam stops. So it minimizes the effect of breathing, because it stops when the organ is out of the planned position, and it minimizes dose spill to the surrounding healthy tissue. So it's very precise radiotherapy. And we prefer the MRI planning, as you can see here, because you can see the contrast between the tumor in the middle, and in this image you can see the kidney here, and you can see the contrast of the tumor here in the kidney, and this is the CT planning, where it's not that very clear where the tumor is. And I will show this image now. You can see clearly the movement of the kidney because of the breathing, and you can see that the planned position is actually stays here in this red circle. So you can see it very clearly here, and that's why we prefer the MR over the CT planning. So after 2018, when we had our first MR-Linac, there are many other centers who acquired an MR-Linac. You might see your own institute here on this world map, and there are many other countries who are also acquiring an MR-Linac at this time. I've looked up for Italy where they are. There are 4 institutes in Italy who have an MR-Linac. I think one is just outside of Milano. And we are collecting all the data that are now being processed, all the MRI scans, CT scans, and we're collecting it in a big data set, the Momentum Consortium, and we believe that we will have very nice data in a few years on the MR-Linac results. So let's go back to the renal cell carcinomas in VHL, because we know there are multiple, bilateral, and they occur from a young age. And the goal of our treatment is to detect and treat tumors before they progress to metastatic disease. And very importantly, of course, is to preserve kidney function. So we do this by active surveillance and timely interventions. So these are some Utrecht data, and the group here on the left is historical cohort, and these are from the last 12 years. I will focus on the type of treatments. We have moved to a lot of local therapies here. You can see that now the recent years, almost 75% we treated with microwave ablation or radiofrequent ablation. And in Utrecht, we have a group of patients that we are following up from a very young age. So we see all the tumors occurring, and that's why we tackle them at a very early age. And that's the reason I believe that we do a lot of local therapies nowadays in our hospital. But of course, I do think there is room for other non-invasive treatment options for renal cell carcinomas, and especially for people coming from the US. Belzutifan is not available in most European countries at this time, and we don't have any prospect now when belzutifan will be available. So I think it's very worthwhile to continue investing in local therapies in our patient groups until we have belzutifan, of course. So what does the evidence say? There was a very nice review published recently on sporadic renal cell carcinomas, a review and meta-analysis, which included 13 prospective studies, almost 300 patients, single arm, of course, and the median size of tumors was 5.5 centimeters, and of course an elderly population in the sporadic tumors, renal cell carcinomas. Safety, a very important issue. There were only 40 patients who experienced grade 3, grade 4 toxicity because of radiation. We saw fatigue, abdominal pain, 2 patients who had a decrease in renal function, a significant decrease in renal function, but the average, so the median renal function decline was around 10 milliliters per minute, so that is quite reasonable. This is we can see here the local control rates. After 1 year, local control is 89%. After 2 years, we see a local control rate of 87% of all the different studies here, and after 3 years, we see a local control rate of 95%. So the tumors, we see them decreasing or not growing at least. What do we know about radiotherapy in our VHL population? There's up to now only one prospective small study of 7 patients, and of course a high dose, median dose of 50 grays in total. Primary endpoint in this study was also local control, and secondary the safety issues. And patients were included with small tumors, as we see now in our, I think, local practice also. The patients we treat locally with RFA or microwave ablation, we also tend to treat quite early. And patients were allowed in the study if they had previous nephrectomies, partial nephrectomies. So we see a younger age, of course. And 3 patients had a partial nephrectomy before receiving radiotherapy. And the safety issues, only 1 patient had mild flank pain. There were no grade 2 toxicities in this population. And we see a decrease in renal function after 2 years of around 14 milliliters per minute. It is a high dose, what I already discussed, and the local control was excellent. After 43%, we found a local control of 100% in this group. It's only 7 patients, of course, but we can see it here in this figure that there is a decrease in tumor volume after many months. So when can radiotherapy be considered? In my opinion, when partial nephrectomy is not possible, when local therapy is not possible because the tumor is near ureter or near vascular structure, so you might have a heat sink effect, so you rather not do the local ablations. And of course, as I just told you, that belzutifan is not an option for us now. And it's the question whether, when you have localized disease, if you should start belzutifan. So I think that there is a place for radiotherapy. The future, I think there is some good short-term local control, long-term data are lacking. And that's what we are working now in Utrecht on acquiring more long-term data for radiation therapy. But the short-term safety is comparable to other local options. And it's a non-invasive option for patients. Patients just go in and out of the hospital. They continue their daily activities after this treatment. So for the patient, I think it's very patient-friendly. And we prefer the MRI accelerator because we think we have less toxicity. It's cheaper, but it also depends, of course, on your local economic situation in your country. less fractions, and the radiotherapists in our hospital think that they might even treat patients with only 2 or 3 sessions. So patients can continue their daily life activities. Of course, as you have heard before, I'm an endocrinologist, but I'm also the lead of our VHL program, so we work closely in a team with radiation oncologists, radiation biologists, and we have a collaboration with the Royal Marsden in London with the oncologists. There's also an Emmerlinac there. Accrual goes very slowly in this population, so it will take a long time before we have the long-term data on safety and on efficacy. But I think that there could be a place for a radiotherapy in a select group of our patients. Thank you for your attention.
Thank you so much, Rachel, also for saving 20 seconds on your time. So you're perfectly on time. So any question from the floor? Please, the microphone. Professor De Cobellis, you are.
So thank you for your lecture. I'm Professor De Cobelli, interventional radiologist. So I appreciate your topic. So as you know, as you said, one of the most important critical issues for interventional radiologists are the ureter, of course, the pelvic system. I don't think the problem is the vascular system for ablation, especially for microwave or cryoablation. So my question is a lesion close to ureter a contraindication for radiotherapy, or is not any contraindication? Are any risk of having late fibrosis and late stenosis with radiotherapy, as well as you know, ablation?
Yeah, so we know that can be a case with local therapy, with the ablation we know right now. The experience we have is that also larger tumors can be treated with radiotherapy. So this is on the sporadic group, not the VHL group. And yeah, the data we have is short term. We don't see the problems at this time. So yeah, we have to see for the future if we see that there are strictures, but at this time we don't see those problems.
Thank you. Other questions on the floor? So I have one brief. You said cheaper, but is possible so far to have a cost per patient with these new techniques or not?
Yes, I heard in our hospital that the session for renal cell carcinomas is around 10,000 euros. I don't know if it says anything, because I know the cost can differ, but it's around 10,000 euros.
Because, you know, in Italy, it's also an issue. Cost per patient, cost per treatment is an issue when you have to choose several options like ablation in terms of radiotherapy or thermal ablation or surgical resection and so on. And I don't know, just a question, but I don't know. You know that CyberKnife is another radiotherapy. It needs probably a fiducial marker to be put in an invasive, minimally invasive way, because we have to put there. Have you any experience on CyberKnife as an alternative as for MR guided?
Not yet.
Not yet, not in your institutes. Okay, I feel that we can go forward with the next and a new talk by Professor Larcher from here, from Italy, from San Raffaele. His topic is a systematic assessment of surgical outcomes in these and I feel other kinds of hereditary renal cell carcinoma. Please.
Thank you very much. So this is our past, this is our history. I've decided to start my talk with this case that is a patient that has been taken care of here at San Raffaele since more than 20 years. So from the very beginning, the major clinical issue was bilateral synchronous clear cell renal cell carcinoma. And following a first attempt, which back in time was kind of pioneeristic to control the disease by means of systemic therapy, even if the patient was without metastasis, we observed a disease progression, and we were bound to treat one kidney with a radical nephrectomy. Following an attempt to perform nephron-sparing approach on the contralateral kidney, again, the disease progressed, and the only option left was to go for replacement therapy following the second radical nephrectomy. This was not enough to control the disease because the patient had also systemic progression at the level of the lungs, testicles, and also this nodule that was removed from the external auditory canal at final pathology resulted clear cell carcinoma metastasis. So clearly this treatment paradigm was not effective in this case, but luckily enough, it is entirely outdated, also because we can intervene in a different time frame. So basically, this is what contemporary surgery for renal cancer looks like. We are inside of the belly, inside of the abdomen. We are looking at the kidney with a scope. Those instruments are remotely controlled by means of a robotic console. This is the right kidney, and this is a renal tumor. It is possible to perform an ultrasonography of the cancer directly on the tissue in order to plan the surgical resection. And basically, you see down below here under the suction device, you have the healthy renal parenchyma. This is a CT1A clear cell renal cell carcinoma. And basically, with a combination of sharp and blunt maneuvers and dissection, it's possible to excise it. And you see, sometimes you can peel the tumor out from the healthy tissue, and it's very clear that the nephron loss in this specific case, it is basically minimal, and the resection bed is at least free from macroscopic tumor infiltration. Both kidneys receive 25% of cardiac output, so practically speaking, after the resection, you need to close the hole, and we use this kind of running suture to avoid hemorrhage and postoperative bleeding and complication, and that can be also enhanced with some additional maneuvers like glue or tissue sealant. The big question is, does it make sense to discuss local treatment for clear cell renal cell carcinoma in the hereditary setting today? We do not have any approved agents in Italy and in Europe today. Very likely we will have it tomorrow. So what's next? It would be ideal to have a perfect systemic agents to treat this disease because we will discuss later on the issues related to local treatment. But very likely the management of these patients will become a true multidisciplinary management based on a combination of local and systemic agents, and we can be as creative as possible into designing the studies to elucidate this context starting from a model in which we imagine a continuous F2 alpha inhibition and then surgery only for those tumors that we have so earlier on can be intrinsic or intrinsic resistant or can acquire a resistance. Or on the other hand, and this was basically the setting that we have the most information so far, let's say we clean the patient, we target the most aggressive nodules in order to have the patient eligible for the clinical trial that we have so far. When we want to apply data from clinical trial in the clinic, it's always important to measure the generalizability of the findings. And in this simulation, what we have done, we have tried to apply the inclusion and exclusion criteria of the MK study retrospectively to our real-world population, and we found out that theoretically less than 10% of our population would be eligible for the study. Now, I want to be very clear on that. Very likely, also, all the other 90% patients will benefit from the inclusion and from the systemic therapy, but the thing is, we don't know yet. And this is the reason why data coming from surgical series provide valuable information about the biology of the disease. So since the inception of our program, going back also to patients that were treated before the formal starting of our VHL program, we have treated for renal cell carcinoma 25 patients that were diagnosed with a confirmation of positive genetic test. That in this very peculiar population means more than 50 individual treatment for targeting more than 100 individual clear cell renal cell carcinoma. And I think this tells us that in this very peculiar setting, if we rely on the usual methodology that we apply to oncology in general, it's almost impossible to properly track the outcome of our patient, because when we want to understand long-term patient outcome, clearly the patient is a case. But when we want to understand the morbidity of the treatment we deliver, each individual treatment should be defined and regarded as a case. And when we want to understand the biology of the disease, each individual primary should be regarded as a case instead. That means that we have basically 3 different data sets into one. So, for example, if we look at the morbidity and the type of treatment that we deliver, in more than 15% of our patients, the treatment was based on a combination of different techniques, either multiple partial nephrectomy, one partial nephrectomy, one radical nephrectomy, combination of nephrectomies and ablation. And that means that we cannot really compare the morbidity and the clinical outcomes of this peculiar population to the ones we are used in the sporadic setting. Indeed, the rate of major complication following this treatment was 16%. And please note that in surgery, when we define, our definition of major complication is something that requires a maneuver under another anesthesia. So this is a clinically relevant adverse event for the patient. This is an example. It is one of the most problematic cases that we had to face since the inception of the program. This is the MRI scan of a 52-year-old patient in which the major clinical issue was clear cell renal cell carcinoma. You see, basically, there are multiple solid nodules and simple cysts bilaterally. The patient was already treated on both kidney with previous partial nephrectomy and ablation. So when the cases are that complex, we have the support of a team of engineers that helps us in understanding the anatomy. The purple one are simple cysts that we know phenotypically and genotypically are benign, but look at the amount of healthy parenchyma at the level of the left kidney. The entire kidney is almost suppressed by the presence of the orange nodules, which are clear cell renal cell carcinoma, and indeed the left kidney was silent at the renal scan. So no renal function, full of cancer. The indication was for radical nephrectomy, and instead, on the level of the right kidney, we have planned a combination of partial nephrectomy and tumor ablation in order to maximize the chance of avoiding replacement therapy. In this case, the choice was for an open surgery because the indication was to treat both kidney in the same session. So it was a bilateral local treatment, and this is justified by the fact that on the left side we were performing a radical nephrectomy. So this is the section of the left renal hilum and the removal of the kidney. This kind of mapping system is also the base of the work of the pathologist, because otherwise it would be almost impossible to understand what is what. So moving on, this is the preparation of the right kidney, and again we relied on the support of our 3D models to map and count each individual lesion. In order to ease a little bit our life, we had to clear the renal cyst to understand the anatomy. Now the indication was to perform a tumor ablation that was performed by Professor De Cobelli, scrubbed at the surgical tables together with us. You see, it's possible to insert a needle directly in the kidney under ultrasonographic guidance and to control the local tumor destruction by means of thermal ablation using microwaves. The indication in this case was to treat the most complex and endophytic lesions with this approach, and instead, let's say the easy one, were treated by means of surgical resection. And you see that basically the same principles that we have discussed for open surgery were applied also in this setting. The resection plan is as close as possible to the tumor in order to maximally reduce nephron loss. And in this specific case, since the patient was already a single kidney patient from a functional standpoint, the resection was done without hilar clamping, so with no renal function detriments related to ischemia. Luckily enough, following an anticipated acute kidney injury with the rise of serum creatinine up to 6, the urine output was maintained, and then the renal function at the end of the hospital stay was acceptable. The patient was discharged without the need of systemic therapy. So according to this system for data collection, it is possible to estimate the long-term outcomes of this patient population, and in our institution, the expected number of surgery per patient were already 2 at 40 years of age, targeting at least 4 individual tumors. We, in our population, observed a life expectancy that was way higher than historical data that we have in the literature reporting a median survival of 50 years of age. Nonetheless, the risk of systemic progression was not negligible, with being more than 25% at 60 years old of age. The risk of dialysis or transplantation, or need for transplantation, following a bilateral nephrectomy was 25% at 50 years old. This is, I think, the most important findings of our analysis. So we wanted to evaluate tumor by tumor cancer aggressiveness from a phenotypic point of view, because we gave our indication for active treatment of surveillance based on clinical sites, but those data are based only on historic observation, looking at the risk of metastasis in the sporadic setting, and might not be applicable in a completely different setting. So the first disappointing, if you want, finding is that in our overall population of more than 100 individual tumors, the rate of aggressive disease defined as either high grade or high stage or high grade at final pathology was 17%. And when this figure was stratified according to the tumor dimension, even in the subpopulation of very small clear cell renal cell carcinoma, so with a diameter smaller than 3 centimeters, it was more than 10%. So this information have critical implication when it comes to active surveillance, because the keynote is that very likely we are badly in the need for better biomarker to understand the triggers for active treatment. And then the discussion about what would be the best active treatment in the future is more than open, and very likely, as we said, it will be a combination of local and systemic agents. But the unmet need so far is to understand which tumors can be safely observed and which tumor instead requires active treatment. Thank you very much for your attention. I want to thank all my team that collaborated on our program. Thanks a lot.
Thank you, Dr. Larto. Also perfectly in time. So I would like to ask the audience if they have questions for Alessandro.
No questions? Just one. You work with the intervention radiologist, or you do the ablation by yourself, or is the same according to your?
No, that was delivered together with the interventional radiologist. I would say the interaction is extremely close. So practically speaking, the organization is that Whenever there is whenever the indication is for active treatment, each case is assessed through an MDT, and way before surgery, we plan what to do lesion by lesion. Okay, the plan, it's not always 100% what we do in the OR, but the tumor ablation is delivered by the interventional radiology, which, by the way, was Professor Dacobelli, together with us, scrubbed in the OR. Please.
Thank you for your talk. Do you have a preference between cryo and microwave ablation to possible lesions?
That's a question for the interventional radiologist again. So I don't know, do you want to?
It's quite easy in my experience. So for the smaller lesion, the easier lesion radiofrequency is a good and standardized option. For a little bit larger lesion, more close to the hilum, probably cryo is better, is less invasive. However, it depends on local expertise and so on.
Another colleague here.
Yes, just to focus on this problem, I completely agree with Andrea. However, when we talk about this kind of treatment in operating room, we have to have something very quick. If we have to ablate something like 10 lesions, we cannot have like 30 minutes for each lesion, like cryoablation. So we have to use microwave. Absolutely microwave. It's the only way to treat something like 8 or 10 lesions in the same time, because microwave ablation needs 2 minutes for each lesion and not 30 minutes like cryo or 15 minutes like radiofrequency ablation.
So how many groups in Italy have we that could work together? I feel
That's a very good point. So all the colleagues from the Istituto Oncologico Veneto are here with us, and they were the very first center in the country coming up with a structured VHL program. But we firmly believe that in this specific field, and this is not an issue related to urology only, centralization is key, because without centralization, basically nothing is possible. It is not possible to gain the appropriate knowledge to understand the disease. It is not possible to aggregate the amount of data that you need for a clinical trial, an observational protocol, or whatever. And without centralization, it is not possible to create a team that can set the priority for patients that are so complex.
Yes, I agree on that, and I think it would be very worthwhile to, in Europe, see all the different centralized centers, if we can work also together. Yes.
Thank you. Thanks a lot.
Thank you. So we move now to our next speaker from Spain. Dr. Muini will talk about developing prophylactic and therapeutic gene therapy for von Hippel-Lindau syndrome using adeno-associated factors. This is a preferred abstract session.
Hello, everybody. My name is Pedro, I'm a PhD student from Applied Medical Research Center in Spain. It's a great honor to be here and present our research on VHL syndrome treatment by adeno-associated viruses. As we know, VHL syndrome management mainly relies on diagnosis by genetic tests and monitoring and early detection of disease in people predisposed to these conditions, and treatment mainly based on chemotherapy and removal of solid tumors. Among non-invasive treatments, growth inhibitors and angiogenesis blockers are found. However, currently there is no curative treatment for VHL syndrome management. Gene therapy, instead, is a medical modern method that offers a prophylactic and curative approach for VHL syndrome, which is going to be my main topic here. What is gene therapy? Gene therapy is a revolutionary medical method that utilizes genetic material as therapeutic agent, and it usually works based on delivery of functional genes to the target cells. And sometimes it works by correction of defective genes in patients. In gene therapy, therapeutic agent that could be a DNA or RNA molecule are introduced to the cells using a delivery vehicles or what we call vector. Vectors are usually non-viral vectors or viral vectors. Among viral vectors are found they are commonly AAV or lentiviruses or adenoviruses. AAV or adeno-associated viruses are the main leading platform of gene therapy in vivo. Wild-type AAVs, wild-type AAV vectors, are small, non-enveloped, non-pathogenic, and naturally replication defective. They are low immunogenic from Parvovirida family of viruses. They have a single-strand DNA genome, which is flanked by 2 ITRs. Recombinant AAV vectors that are used for gene therapy, for their production, the viral sequence is replaced with a therapeutic cassette and a promoter that controls transgene expression, and this cassette is packaged inside a capsid and delivered to the target cells or patients. Different AAV serotypes exist with various tissue-specific characteristics that determines their tissue tropism. As you see some examples here, for example, AAV2, AAV4, AAV8, and some others can transduce renal tissue cells, or some other vectors that transduce eye cells, and for some other organs as well. Gene therapy studies for von Hippel-Lindau syndrome treatment mainly have focused on VHL-HIF pathway targeting, usually by DNA transfection, and usually in vitro level. But the potential of recombinant AAV-mediated gene therapy is not explored. The only relevant report is AAV8-mediated delivery of RNA interference system to target HIF-alpha. With this background, and since VHL syndrome is due to mutation in VHL gene leading to absence of functional VHL protein, HIF-alpha accumulation, and tumor formation, we hypothesized that expressing an appropriate level of VHL protein in patients using recombinant AAV might prevent tumor formation. In order to test our hypothesis, we generated AAV vectors carrying VHL gene and evaluated their efficacy in renal cancer cells. To do so, we produced 3 vectors, AAV3B, AAV2, and AAV-DJ, different serotypes that express VHL protein. And then we checked transduction efficacy and evaluated VHL and HIF-alpha expression levels in the cells. Our cell model was human renal carcinoma cell line, or RCC4. This cell line is deficient in VHL expression, so it's a precious model to check VHL expression in the cells. We infected this cell line with several multiplicities of infection, 5E2, 5E3, 5E4, and 5E5, 3 wells per group. Then we checked RNA sequencing of cells as well to assess HIF-alpha pathway influence from our VHL treatment. We observed VHL expression in RCC4 cell line at highest MOIs. Here are shown results of AAV2, 3B, and DJ. As you see, AAV2 could successfully express VHL at 5E4 MI, and DJ successfully at 5E5 MI. Our control negative cells here were RCC4 wild-type cells that they are VHL deficient and cannot produce VHL. Also, we included a control positive cell line, which is RCC4 VHL cells. They have a plasmid, and thus they overexpress VHL. They serve as positive control in our experiments. Then one step further, we aim to see if we can reduce HIF-alpha in protein level by our treatment. And we transduced RCC4 cell line with AAV-DJ serotype carrying VHL gene. As HIF-alpha has two bands, usually is observed by 2 bands, HIF protein. If you check the upper bands, AAV-DJ-VHL could significantly and successfully reduce the HIF-alpha protein at 5e2 MOI in low MOI, which is also very good. VHL expression basically reduce HIF-alpha reduction, then it should it should lead to late tumor genesis. Our control negative cells, which were RCC4 wild type cells that cannot express VHL, so they had sharp band of HIF-alpha protein. Control positive, which is RCC4 VHL, they have a plasmid again, they express VHL, so they don't have HIF expression, they serve as our control positive. Then we aim to see if our treatment can reduce human vascular endothelial growth factor, VEGF, in mRNA levels. Basically, VHL expression reduces HIF-alpha level, and then we will have less VEGF mRNA, which leads to less tumor genesis. In order to test this, we infected the same cell line with AAV-DJ, 5e4 viral genome per cells, and we checked VEGF mRNA level 48 hours after that. Our treatment were RCC4 wild type without treatment, AAV-VHL, our AAV-DJ-VHL treatment, main treatment. We also included a AAV capsid that transduces luciferase gene to rule out the effect of AAV alone, and also we included RCC4 wild type as control positive as well. We witnessed that AAV-DJ-VHL treated cells successfully had significantly less VEGF mRNA level compared with AAV luciferase treated cells and also RCC4 wild type cells. And we then sent the RNA extract of all these cells to the RNA sequencing analysis. And we had a close look in VHL HIF pathway genes involved usually in growth and in angiogenesis. We witnessed that genes involved in angiogenesis, neovascularization, tumor growth, cancer progression, metastasis, glycolysis, and even iron metabolism were significantly downregulated in our AAV-VHL gene. Blue color here is downregulation, and red color is upregulation. As it comes from this heat map, it's clear that our AAV-VHL treatment could significantly reduce the mRNA level of these important genes in HIF pathway compared with RCC4 wild type, non-treated cells, and also AAV luciferase that rules out the effect of AAV. It is very important to know that all the genes that were significantly reduced in AAV-VHL, our treatment, compared with RCC4 wild type, also had significant downregulation in AAV-VHL versus AAV luciferase. That shows the effect does not come from the AAV, and it is exclusively for the treatment, VHL treatment. We also did a gene set enrichment analysis for this RNA sequencing. Gene set enrichment analysis is a computational method that shows if a set of genes related to specific pathways are upregulated or downregulated in all data set that we have sent to RNA sequencing. Red color, again, is upregulation, and blue color is downregulation. We observed significant downregulation of genes in RNA-seq related to pathways of HIF and clear cell renal cell carcinoma pathway. Only in AAV-VHL compared with RCC4 wild type and AAV-VHL versus AAV luciferase. That again rules out the effect of capsid only. Conclusion: different AAV serotypes can express VHL protein in RCC4 cell line. AAV-mediated VHL expression is inversely related with HIF-alpha protein levels. AAV-mediated VHL expression reduces human VEGF mRNA levels in RCC4 cell line. AAV-VHL delivery leads to loss of enrichment of genes related to HIF pathway and clear cell renal cell carcinoma development, which is very important in the patients with VHL syndrome. Our take-home message is potential of recombinant AAV-mediated gene therapy to restore functional VHL protein, to downregulate HIF-alpha expression, to inhibit HIF-alpha downstream oncogenic genes, offering potential prophylactic and therapeutic strategy for VHL syndrome treatment by preventing tumor formation. Our next step would be to launch these studies in vivo using animal models to check vector tropism and effect in tumor-presenting organs, including central nervous system, liver, eye, spinal cord, kidney, and pancreas. And we will check expression analysis of HIF targets like VEGF, the same in cellular model, angiogenesis and apoptosis pathways, RCC4 tumor cells implanting in mice model, and then treat them with AV-VHL treatment, and also to check long-term efficacy and safety of the treatment. At the end, I would like to thank Gloria Gonzalez, my supervisor, our colleagues in DNA and RNA Medicine Division. Here our contact, if you need to reach out, we are so eager to have a collaboration, especially if you can offer us a precious animal model. I know it's a bit difficult, but we are here to collaborate with you. Our profession is gene therapy, and we are here to collaborate with experts in von Hippel-Lindau syndrome. Thank you so much, and I will be happy if there is any suggestion or comments or questions.
Thank you very much. We are a bit behind on schedule, so maybe you can save the questions for later. And then we will close this session and we move to the next session.
Thank you all. Thank you very much.